Okay.
Okay.
Easiest question. Can you say and spell your first and last name?
It's Craig, C-R-A-I-G, Towers, T-O-W-E-R-S.
Okay. And what do you do here at UT Medical?
I'm a specialist in high-risk obstetrics. The title is maternal fetal medicine specialist.
Okay. All right. And we're just going to dive right in, if that's okay.
Sure.
Can you describe to us what happens from your standpoint when a child is born addicted to drugs?
A child that's born dependent on opiates often will go through a withdrawal type process called neonatal abstinence syndrome. It varies from child to child, but in the classic sense of the word, it's fairly brutal to watch. They can't be held, can't be stimulated, they cry all the time, they have diarrhea, they can't feed well, they're irritable, they're hard to console, they have to be in a dark room, and it can last anywhere from as short as a couple weeks to as long as a couple months.
Okay, and do you guys have a wing or a unit here specifically for drug-dependent babies?
Well, our neonatal intensive care unit takes care of them. They don't currently have a specific spot there that involves all those newborns, but they are kind of grouped in a certain area. Our NICU is being remodeled, and then there will be actually a separate space for that. But.
And a question a lot of our viewers have had, with drug-dependent babies, are they expected to break the cycle of what their mothers have done, or what do you think about that?
You mean their long-term outcome?
Long-term impacts.
Well, that's a very good question. There's not a lot of information on the long-term follow-up on these children. There's more than I anticipated. I've been doing an extensive literature search, and to my amazement, not much different than my OB literature, there's information out there that is concerning, scattered throughout the literature in in many different journals and many different specialties, and so it hasn't been coalesced as well. But there are several studies to show that children born of individuals with addictions that have a much higher rate of addiction themselves in the future.
And what does the process look like when a pregnant woman is struggling with addiction?
The process in the country or the process here?
Here in East Tennessee, if we can.
Okay, well, in the country, the protocol has always been to get them off of the street drugs, which is clearly what needs to be done. The street drugs are tainted with substances we're not aware, and many of them are very potent drugs like fentanyl, which is what's resulting in the large number of deaths because of how potent it is. And so they need to get off of those and into a maintenance program, whether that be methadone or buprenorphine. Buprenorphine is often called Subutex, but the real name of the drug is buprenorphine. And that stabilizes them. Now, since the 70s, our protocol has always been to maintain them on that maintenance therapy through to delivery. But then those children will end up going through neonatal abstinence syndrome, 70 to 80% of the time. So the rest of the country, or most of the places in the country, will not do anything beyond that. That isn't necessarily saying it's bad. Those women are off of drugs from the street. They make more prenatal visits, they get good prenatal care, and they get delivery, but it doesn't change the issue that the child has been chronically exposed to an opiate and delivers dependent on an opiate. From my research and the volume of information I've come up, we do it differently here. We offer detoxification to pregnant women once they've stabilized themselves into a methadone or buprenorphine program.
Can you tell us more about that program?
Yes, when I first came here, I was somewhat amazed as to how many pregnant women I saw with opiate use disorder. And I would say for the first year and a half, would tell them that we don't recommend detoxification during pregnancy because it was harmful to the baby. And ultimately I went to the literature to get the proof as to why we've always recommended that, and put it together in a pamphlet with some bullet notes. And instead of repeating myself over and over to all these patients the same scenario, I was going to supply them with this information to make it simpler. And to my amazement, found that that recommendation was based on 2 single patients in the literature, 2 case reports of two women. So I did a study that was published in, I think, September or October of 2016 that reported on 300 plus patients that were pregnant that we fully detoxed with no problems or complications or any issues, and the babies all did great. I would love to say I was the first in that arena. There were 5 other papers prior to me that had done that. The earliest being in 1990. They were scattered in 5 different journals in 3 different specialties over a period of 23 years with patient volumes of anywhere from 35 to up to maybe 80 patients. And so those 5 studies together averaged a little bit over 300 patients, so mine doubled the number. But we now have well over 600 plus patients published that shows detoxification is not harmful. So we offer detoxification. We don't coerce a patient into it. We don't make them feel guilty about it. They have reasons as to how they got into this situation in the first place. But if they are interested in detoxification, we have a protocol that we follow to work on getting them off.
Okay, and what's the protocol?
So if I was to take my practice, our practice here, if I have 100 women who are dependent upon opiates, about 80 of them are interested in detoxification, and we completely succeed in 2/3 of them. So about half of our population ends up being detoxed. The other third that they get down to a very low dose, but they don't get completely off. And then there's about 20% that prefer not to detox, and we can maintain them on methadone or buprenorphine. If they're detoxed, the babies don't have any neonatal abstinence syndrome. We've been working on some long-term follow-up information on these kids, and I know in my heart that detoxification is clearly a viable option and may actually be the recommended option in the future once further research gets published. Now, basically the way I do it is most of the patients here will get on buprenorphine, we stabilize them, and then we slowly taper them off as an outpatient until we get them off. And then we have some other things that we're doing from a research standpoint to maintain their sobriety until they deliver. And then we continue with behavioral health. Now, the key aspect to this is behavioral health is an integral part of this. We have it actually in our office, so when the woman comes to her visit for our clinic, which primarily now is held on Tuesday afternoons, but it's pretty stuffed. They see us, they get an ultrasound if it's scheduled for that, they have their behavioral health, and that way they're not having to travel to 3 or 4 different offices.
Okay. And is it often that women who are addicted to drugs and they are pregnant, are they scared to get help?
Yes. A large number of women are afraid to come for fear that DCS, Department of Children's Services, will get involved and they might lose the child. But you know, we have a good working relationship with DCS here in the Knoxville area, and they know that if they're in our program, if they're in a program, DCS will always be involved in any child that's been exposed to an illicit substance. But that doesn't mean DCS is going to take the child away. If they're in a program, usually they do not. But that's one of the deterrents.
Is there anything about the opioid epidemic that keeps you up at night or just really gets to you?
I think what gets to me at this point in time is the pushback that I have received from the detoxification process, when clearly there is no literature to support their argument. They have those 2 case reports and then theory, and I have facts. So, but in medicine, nothing ever changes quickly. In fact, the rule of thumb, though I hope it's quicker than this because I'll be retired by then, is that when something is done, it takes almost 17 years for it to ultimately get changed in medicine. That's how slow the process is. So I've been fighting this battle for about 3-4 years now, but I'm hoping in about 2 or 3 more years we'll get it fixed, and so I'll get it done in 6 or 7 rather than 17 years. But
who's providing the pushback?
the majority of the pushback's from the addiction medicine specialty groups.
What do they prefer? Can you tell us?
The addiction medicine specialty group does not believe in detoxification. They believe in maintaining them on Subutex, buprenorphine, or methadone. And many of them even argue increasing the dosage of methadone and buprenorphine as the pregnancy goes on so that the patient's on a maximum dose by the time they deliver, which only gives you an 80% chance that the child will have NAS. Interestingly enough, not every child exposed to opiates has NAS. Some babies do not. My apologies. I should have been. It's regional. Sorry about that.
No, no.
You can edit that part out.
No, we absolutely can. Let's see here. Is there sort of a stigma with drug-addicted mothers?
Definitely. You know, for the country, it's a fascinating scenario. Where the explosion for the opiate epidemic came from is the massive number of opiate pills that end up on the street. It's an overprescribing by the medical community of opiates for chronic pain. But the problem there is not the fact that they're prescribing it for chronic pain, is that the patients have this cycle, many of the patients, I shouldn't say all, some of the patients have a cycle where they only use a portion of it. In many cases they have to pay for their opiate medication out of pocket, so they can sell half of what they get to get enough money to buy what they need, and it's a circling process to where there are tons and tons of opiate pills on the street. Therefore, someone who is interested in experimenting with drugs, one of the deterrents with opiates was the only way to get there was to inject yourself with a needle. That was heroin. And that was a deterrent for a large number of people. So that's why they shifted to cocaine or methamphetamines, because that's snorting or taking a pill. But when the pills ended up on the street, it was easier for them to take the pill. The difference between opiates and something like amphetamine or cocaine, which are also not good, is it produces a physical dependence to the point where if you don't take the drug, you go through a terrible withdrawal. It involves opiates affect what's called our autonomic nervous system. Our nervous system has motor function, sensory function, and the autonomic nervous system controls heart rate, your intestinal tract, sweating, and they get an over production of this. There's an explosion of the autonomic nervous system when they don't have the opiates, to the point where they're sweating, they have stomach pains, they can even have seizures, they have diarrhea, they have nausea, and so withdrawal is a terrible thing to go through.